All right.
Just to start, I like to include this slide when I give presentations on this for kind of two reasons. One, I'm originally from the Appalachian region of East Tennessee, so it's a nice excuse to put a photo in the talk from that. But in general, I think it's also a good illustration of with clinical trials, in particular when we think about large clinical trials or we're doing statistics for large clinical trials, we can often think about this wonderful, beautiful land of asymptopia, where as far as you look, everything looks like a normal distribution. And in the world of statistics, that's nice because we have lots of large sample theory that if things are large enough, things look like a normal curve, and it really simplifies the process of doing things. One of the challenge in small clinical trials when the sample sizes are not as large is many of those properties no longer hold, and the distributions are much more complicated to work with, and the designs in general are much more complicated to work in, which gets to the point that I raised just a minute or so ago, that the process of designing small clinical trials is much more complicated because of some of these issues and some of standard statistical theory. Not everything can be assumed to follow this bell-shaped curve, and so much more specialized techniques and more thought and design are often needed. Now, one of the things that comes up when you hear the phrase small clinical trials is what exactly do we mean by small clinical trial? And I think it's important to keep in mind that the answer to what is a small clinical trial depends on the context, often in the disease or where you are. So a stroke researcher may think of a small clinical trial as an early phase trial, whereas an ALS researcher may think of a confirmatory phase clinical trial as a small clinical trial. So I think we'll address both. I'll focus on kind of small trials in general. I will spend more of the time in this discussing more of the early phase trials, which would apply as a kind of a small trial in any disease area. But I do think it's important to keep in mind that by small trials, I'm not only talking about early phase trials for rare diseases or for other types of situations. You may have confirmatory trials that would also suffer from many of these challenges with small trial issues. I will focus strictly on the statistical issues. There are lots of operational issues, recruitment issues, rare diseases, how do you find sufficient number of patients that are also, I think, extremely important in these settings, but I won't address those today. I'm going to focus mostly on the statistical issues. I do think one of the things that is important to keep in mind is there's no single one best approach. And the other part that comes up with small trials that I think is challenging, because much of the training in clinical trials, if you've taken a clinical trials course at a university, a lot of the discussion tends to focus more on the confirmatory setting and the regulatory setting opposed to that. It's important to keep in mind, just like our children aren't little versions of us, small studies are not little versions of large studies. And so with any small study, we're sacrificing something. And I think part of the planning discussions that go into, that take place when designing these types of trials are coming up with some sense of what we're willing to sacrifice, right? If something has to trade off, do we want a less definitive outcome? Do we want to address less precision? Do we want to relax the type 1 error rate that we will consider for declaring significance and moving forward? All of these are important things that have to be addressed because there are lots of competing challenges. If you look, there was, this is about 10 or 15 years old now, there's a National Academy of Sciences document on small clinical trials, which led to a number of key recommendations. If you happen to read through that, you can see I've summarized them here, which are define the research question, tailor the design, clarify methods when reporting trial results, perform corroborative statistical analysis, exercise caution in interpretation, and more research on alternative designs is needed. So it's interesting, that comes from a small clinical trials, but really that's no different from any other trial. So the important point here is that just because it's a small trial doesn't mean you can relax the need to come up with a strong scientific research question that's adequately powered, has some sense of threshold to address a question, interpreting in the correct context and trying to come up with, with alternative design. So all of these issues are no different in the context. The challenge is to come up with the basic requirements for any trial. What's the important research question? Are you using a rigorous methodology, and does it have adequate ethical considerations to ensure that the risks to the subjects are minimized? Those are all requirements for any clinical trial, but often in the small sample size trial issue, you may have to relax one or more of these. So you may have to consider more risk. You may have to use a slightly less rigorous methodology. You may have to relax your criteria for declaring significance. It's important to have those discussions, as I mentioned a minute ago, but there's a big difference between doing this prospectively and thinking ahead of time, what are we willing to relax? what are we willing to hold firm on, versus getting to the end and trying to decide retrospectively how you want to address this. I've said this in a number of talks recently, and I think it's worth everyone on this call hearing that in my experience working with clinicians are extremely good at two things. They're extremely good at coming up with reasons why unexpected significant findings show significance and coming up with some type of biological explanation behind that. And they're equally good at coming up with reasons for why some non-statistically significant finding might be incorrect because the effect is true, but there was some flaw with the design. So it's very easy to come up with retrospective rationale for why anything has happened. So the more you can prospectively identify your analyses and your questions of interest when working in clinical trials, the better you will be in the long run.
The main issue here is the heterogeneity in progression, whether that's when a person progresses, how quickly they progress, what muscle they are actively progressing on in terms of GNE myopathy. And what that leads to in terms of clinical trial design is large variability in the key clinical endpoints. So lots of variability in the endpoints that we want to study to try to discern if the treatment is different than the placebo group. Of course, common solutions in the non-rare disease setting are we enroll a more homogeneous subset, as I mentioned was done in regular Alzheimer's or sporadic Alzheimer's trials, or enroll a large enough sample size to overcome this heterogeneity. Obviously, these are not tools or not solutions that we can use in the rare disease setting. The first, because we don't want to make a rare disease even more rare by only allowing a very narrow subset of the individuals to enroll in the trial. And the second, because oftentimes we don't have a large enough sample size available to enroll to overcome the heterogeneity. So I'm going to focus on going through these two examples in details, walking you through exactly what we did when designing these trials, how we overcame sort of those complexities and those limitations. But a brief overview for each of these is in both genetic GNE myopathy and DIAN, we were very blessed to have natural history studies or observational studies that provided us with rich data on how individuals progress under natural history in terms of key clinical endpoints. So how individuals progressed cognitively in the dominantly inherited Alzheimer's group, and how individuals progressed on the key clinical muscle groups under natural progression. This allowed us to essentially just know what we're working with, which is one of the key takeaways here that I want to spell out and make very clear is that, especially in rare disease, where we can't just enroll a big enough sample size and hope that we can discern a difference between treatment and control, we really need to understand the endpoints that we're working with. And we really need to have realistic approximations for the power of our designs that we are proposing. Natural history studies are one of the best ways to do this, and oftentimes we are blessed in rare disease that natural history studies have been run. The other aspect of this that I want to describe is more innovative designs or analysis methods. So especially in rare disease, we want to be able to make use of all available data as best as we can. In terms of GNE myopathy and DIAN, or dominantly inherited Alzheimer's network, this comes about by using the longitudinal data, sort of repeated measures or the disease progression of the individuals, and using all of that information to discern if a treatment is different than the placebo group. You'll also see that we can get some power gains, and there's advantages to doing sort of adaptive designs where we have more frequent interims to discern if we have early success, reached early success, and able to, because the treatment is so effective, enroll a smaller sample size. And also using all available data that we have, not just sort of repeated measures, but also using potentially using the natural history data as a comparator to the treated individual.
All right, so sorry about the abrupt transition between the two talks. At least I let them run at the natural speed in terms of turning them up to 1.25. So at this point, we're starting to get some potential questions for the audience, but I think Dr. Coffey and Quintana, would you like to just kind of elaborate a little bit on some of the key points that I brought in from those clips?
Sure, I can go first. I think I would just say, and hopefully this was clear, but I would say the most important thing I could give, or advice I could give, is threefold. The natural history studies is essentially just do your homework, like really, really, really understand this disease before you go running a trial. You can't just enroll a large enough patient population that law of large numbers comes in and now everything will be fine. You really need to understand your disease. So do your homework. The second is get creative. So especially with rare diseases, I would say innovative analysis methods, innovative designs, maybe single arm designs compared to historical controls, can be so important and so beneficial here. And so that would bring me to my last point, which is bring on a statistician as soon as possible to help you do these things. So I would say those are my three takeaways from kind of what Will showed.
Yeah, I would just, I think Melanie summed up the big things excellent. The only additional point I would make, and I think this seems intuitive, and maybe it is intuitive to most people, but I'm amazed at the number of people I've encountered who have thought the opposite. But just because a trial is smaller in terms of the number of participants you can access doesn't make it easier to run or cheaper. It's really inversely correlated. And for some of the reasons Melanie mentioned, if you're being creative in your design, that can be more efficient from a statistical side, but also means there's going to be a higher bar to justify your design to regulatory authorities or grant review groups, because it's going to be different. And so you're going to have to, convince people that it has desirable properties. It doesn't introduce negative consequences as a result of some of those. So often, bringing the statistician on is helpful because there's, in my experience, and probably Melanie's as well, there's more simulation that's needed to justify the designs, more investigation of the properties of the design, because they often haven't been explored, particularly in that disease area before.
I think one of the things that this illustrates is that sometimes there's a place for a trial and sometimes there's a place for really good prospective information about how a disease affects people, including Melanie in the cases of the sort of progressive, more chronic conditions. What insights do either of you have into designing trials for rare emergency conditions, for example?
I don't know that I would say it would be any different. I mean, I know that there are some nuances to progressive chronic diseases, but I would still say you really want to understand your patient population. You want to understand what outcomes you're trying to study, what those outcomes look like. Are those outcomes clinically meaningful? Are they meaningful to the patients? So in a lot of ways, I don't know that it would differ that much. I would probably still give the same advice if I was talking about a rare disease in the emergency room.
I agree, and it's kind of related. There's a question in the box. Is there a site that shows how to design a clinical trial for a rare disease from A to Z, which I think is also kind of relevant here. And that I think the answer is yes and no. I think as Melanie and I both kind of focused on, there's like general principles that I think you could lay out in what you need to do to design a trial, but in any particular disease area, any particular trial, there are often nuances of the disease, nuances of the treatment, nuances of the patient population that are individual. So part of the clinical trial design process is trying to stick to the key things you have to, but being creative and coming up with the best ways to do that in the context that you're looking at. So it's almost like there is a check box of things to do, but it's not necessarily sufficient. It's kind of a starting point, and then there's a lot of details and deviation that have to be kind of fleshed out for any particular study, which I think the other side, when Melanie mentioned find a statistician, it's not just a statistician, it's often a full team, because this is not a quick process. This is usually a long, slow, take several discussions, come up with ideas, and take some time to come up with an optimal design. It's not the kind of thing you do a month before you want to start the study.
I think that's a really good point, in that it does have to really be tailored to the research question, what you think the treatment is, what's the areas of uncertainty, and it can be, it obviously can be challenging. I think in other fields, sometimes, solid tumors, you can shrink solid tumors, and there's kind of ways to measure shrinking solid tumors, but neurological diseases are diverse in terms of what the outcome measures look like, what the progression may be, and similar, and in many cases there may not be these early surrogates, right? If you don't shrink the tumor, the patient is less likely to live, whereas in, say, acute stroke, we know that maybe if you don't reperfuse a patient early and show that there's some improvement in their exam in the short term, we don't know that they're, it's less of a clear relationship, because some people may actually have a great recovery, even if they don't recover dramatically in the first couple of hours after a thrombolytic. Whereas some people who do recover dramatically in the first couple of hours may go on to get worse because of rethrombosis and other things. So I think really thinking about the questions and what are the things to sort of inventory at the beginning of the trial. I think, I don't know, Chris, did you want to kind of talk a little bit more about some of the questions relevant to ask at the beginning of the trial? I think, the really short version is, you as the clinician and the biostatistician have an opportunity to educate each other about, what is going on clinically with the disease, but to look at that conversation as a partnership conversation. The biostatisticians are specialists in distinguishing signal from noise, and you're describing to them where the signal and noise is as best as you can tell. But I'll let the real statisticians weigh in a bit on that.
Well, I think the questions are not different in the rare disease setting. The way you address the questions are, and I think the first meeting is usually, and I use the analogy, it's really, and it because it's pretty accurate, is two people talking a different language who have to come together. Often what the clinician wants to do has to be then interpreted by the statistician back into language that is testable. And that sounds simple in context, but many times it takes numerous conversations to get to that. Because the other side that's complicated in rare disease studies is that in many times there are not validated outcomes in the way that you would typically find in other disease areas. And so, as well as justifying the design, you also have to justify it's a meaningful endpoint. And this is where, there's a push, particularly by FDA recently, for patient-reported outcomes or patient outcomes. And if it's a rare disease endpoint and you can clearly show that it's meaningful to patients, and having patient advocates or patient advocacy groups weigh in can be helpful in making that case. So, it really, in a lot of areas, there may be little to go on in terms of what we typically think of in many other. You're doing a clinical trial in stroke, you kind of have a good sense of what the outcomes are that would be accepted for a phase 3. You may not have that in rare disease. There may be more questions in where sites who are enrolling will find patients, because there haven't been many trials perhaps done in this area. So making sure how you would get them, you may have to fly people in because you're going to have to recruit nationwide, worldwide. So, there's lots of information, but the basic questions are the same. I think that's, if nothing else, that's one take home from today, that designing a clinical trial in a rare disease structurally is the same as any other context, but how you do that is more difficult because of the challenges in the rare disease setting.
Yeah, I agree with Dr. Coffey. I think, it's quite similar. However, I think you have more challenges. And I would say the outcome one is probably one of the biggest, is that you don't have this nice predefined set of outcomes like, oh, everyone always uses this outcome in these types of trials. So that's why I think there's a huge need for maybe like pilot studies or just initial observational studies where you're collecting a lot of data on a few, maybe just a few patients, and you're really learning what's meaningful to them, what's actually changing over the course of the disease, what endpoints would you like to see change over the course of the disease. So there's a real need here to understand endpoints and outcomes, I think, in rare diseases where often there isn't a good understanding for those.
There's a couple of questions in the chat box.
One of them is
about,
oh, go ahead.
I was just saying, one's about how do you define rare disease. We're purposefully staying out of that sandbox because I think different people define rare disease different ways. So we're, at least to me, we're not applying any kind of formal definition because there's different ways. It's really, I mean, it's probably not technically rare disease in the sense of any definition, but any kind of disease where it's more challenging in terms of access to patients. So
yeah, I agree. I mean, rare disease could be an N of 1 study, but the Diane, for instance, is a 60 patient study or 80 patient study. I kind of think of it as, if you had all the money in the world, would you still be limited by sample size? So right. Like, if you're limited by how many patients exist, then to me, it feels like a rare disease.
And it looks like there's another question. In terms of deciding the best methodological approach, what are the key aspects that would help the clinician to decide whether to design adaptive clinical trials or just to use a pragmatic clinical trial versus a benchmark control group or synthetic controls? You want to take that first, Melanie?
Yeah, I would say another key point that I didn't bring up is iteration and communication. So there's no checkbox list of like when each of these sort of innovative methods would be best. I think you really have to talk through what are your goals, what is your disease, and you need to go back and forth with somebody who understands these designs. I know this is not a nice answer to give you right now, but I think it takes iteration, it takes discussion to really understand what are your needs, and then someone who truly understands these designs could say, okay, this is the toolbox that you should be using. I understand your needs. These are the toolbox that you should be using. For instance, at our company, we design adaptive trials, but there are many times where someone comes to us and says, we're going to enroll patients really quickly. The information comes 2 days, or like will come like 2 years after you enroll everybody. And there's just not potential there to do adaptive things because you're enrolling everyone up front. You're not seeing information until 2 years later or a year later. It's not really easy to do adaptive designs in some situations, and they wouldn't be beneficial. So oftentimes we'll even say, okay, adaptive design won't help you here, but it's hard to make a checklist of when it would and when it wouldn't. And it's also hard, I would say, in terms of synthetic controls or benchmark control group, that's also hard. I would say one major thing there is, again, endpoint. Do you have an endpoint that is subjective or objective? And that really makes a big difference in terms of, could you do a single arm trial and compare it to historical controls? How heterogeneous, how different are the people in terms of that endpoint? If it's very, very different, then you might not be able to use historical controls. So there's a long list, I think, that goes with each one of these. And I would say communication, iteration, and having a nice back and forth about what are your needs. And then someone who understands these things can tell you, okay, this is the best tool to use.
And I think kind of expanding on that a little bit, Melanie touched on this earlier when she was talking about having natural history data can be helpful in designing that. And I think addressing a lot of these questions is where the natural history data can really help to get a sense of what might be the best approach and how to approach it. And I think one of the other take homes is if you're trying to design, my personal opinion is it would be very, very difficult to design a really strong and make a case that it's proper rare disease trial without any natural history data, because you're kind of applying a lot of guesswork. And so, you know, it helps if there's a good organized way to collect that data so you have some sense of what is the heterogeneity in the disease progression, how does the disease progress, so that you can capture these endpoints. So, you know, that's kind of outside the clinical trials world in a sense, but the more people work with groups that can provide that structure up front, you know, if there's a desire for subsequent treatments, that data becomes really, really critical.
What are, I guess, Melanie, do you want to talk a little bit about the GNE Myopathy Experience? I think I remember a story where it took a while for the PI to find a statistician who was able to sort of think about the problem. And I mean, we've even had this come up in the clinical trials course. Somebody was basically interested in studying a disease that had, you know, really like a 20-year time scale, and it became hard for us to think about how to do, because it was hard for us to think about how to deal with a disease that lasted for, you know, 20 years, and there was notable changes in outcome over that time scale. Whereas it seems like maybe when they were conceiving of GNE myopathy type designs, until they sort of thought about all that could be learned from the disease progression, it was hard for people to think of a design that could actually learn about treatment effects.
Yeah, so I think there are multiple questions in there. Like, how do you find somebody who can help you with your problem, especially if help means something innovative and not a lot of people are trained in innovative. The good thing is you're all here. So now you all have access to individuals who work in this area. You know, if we can't help you, then we can help point you in the right direction. So that's great news. But then I would also say, you know, be active in your community. So we started the GNE Myopathy project with the NIH. They were actually already doing this, they already knew to do this really nice natural history study. So we don't know what type of trial to run. We're just going to spend our time learning about the disease as much as we possibly can. So I would say that's where you can start, although there is some benefit to, before you even run or start your natural history study, to actually think about clinical trial design first, because you want to think about what endpoints you should be collecting. So it's can be quite circular. But we ran into those running the study at conferences. So really immerse yourself in the area. If you're interested in doing rare diseases, even though you might not follow along with all the presentations, consider going to conferences where some statisticians are speaking on rare disease, or and really try to find yourself and align yourself with somebody who can understand your problem and think a little bit more creatively, I would say. Did I answer all of your questions, Will?
Yeah, sorry, I gave you a sprawling three-part, how do you save the world, and et cetera. There are a couple questions in the chat box that are, I think interesting. One was regarding patient-reported outcomes, and how maybe cognitive impairments could run into those. I think there's a couple questions in this comment as well. I guess one of the things that worries me about patient-reported outcomes, and I'm interested in the other panelists' thoughts, is when they are combined with an unblinded treatment. That I feel better about patient-reported outcomes if group assignment is unknown. And I guess what other thoughts do you two have on patient-reported outcomes in clinical trials?
I think the point you made is a good one. I mean, there's PROs where they're patient-reported outcomes. There's other measures that you can do that are independent of that. But also, I think depending on the disease context, and it still has the, I mean, the blinded is always going to be better, but also there's many rare diseases that might require a caregiver. And sometimes, you know, if the individual is cognitively impaired, the caregiver can also, you know, provide meaningful, you know, input that can be used as an endpoint.
Yeah, and I would also say there's ways to sort of sync up, yeah, caregiver reported, patient reported, and then clinician observed, and try to make sure that the information you're getting out of all of that is similar, so that you're not just getting the patient saying, oh, I feel so much better, because they know that they're on a treatment. I also think that this like push for PRO, kind of underneath all of it, is sort of a push for meaningful outcomes that are meaningful to patients. So maybe not necessarily that the patient reports, but maybe a clear functional endpoint that is meaningful to the patient. So sometimes you want to, what is asked for isn't necessarily exactly what is wanted. And so you don't necessarily need a strict PRO, but maybe like a functional endpoint that is important.
Yeah, I totally agree with that. And I think more so than the type of endpoint or what it is, it's always the so what question, right? If you show a difference at the end of the study, so what? Like, what does it mean? And is it meaningful to the patients? Or as long as you feel comfortable making that argument, I think then you've got a meaningful endpoint.
Yeah, I think the next question is an interesting one. What about when historical data is not available or has less good data quality? Should you be doing a single arm trial? And when you have a limited sample size, which do you sacrifice first, precision or randomization?
I mean, I don't think there's an answer to that, honestly. I think that that's the discussion that the team would need to have. And I think you have to decide in your context what you're willing to sacrifice on. That was kind of the point in the video that I was making in the prior thing, is if you can't do everything, it's much better to have discussions up front on what you're willing to relax and what you're not, as opposed to just, you know, pretending you don't have a problem and jumping in.
Yeah, I would agree. And I would say, you know, for the first question, you know, if the historical data is not there or the data quality is poor, sort of junk in, junk out. So I wouldn't just push to use historical data just because, you know, that seems like a trial design that you wanted to use. If the quality is not there, I wouldn't use it. Now, there's a difference if the quality is not there or if you don't actually have patient level data. I think there's a lot of cool things that can be done comparing single arm trials to model estimates of historical data. So you don't necessarily need patient level data. You can do comparisons to simulated historical data and things like that as well. So you can get creative with that. But if it's junk, then I would certainly not try to make a comparison to it in a single arm trial.
And I think, I mean, to expand on the data quality question in a slightly different context, the data quality question is also important when you're actually running a rare disease trial, and that, you know, little sloppy aspects in data that you can get away with in larger trials are going to have bigger impacts in a rare disease study. You know, if you have a 10% dropout rate and you lose 50 out of a 500 patient study, that's not going to have anywhere near the impact if you lose 5 out of a 50 patient study. So, you know, retention, data quality, making sure you're squeezing as much efficiency out of the data, and an operational or even retention, keeping participants in, is going to be critical too. So it's the data quality up front, but the data quality during the study, you know, any little, so you're deciding what you want to give up in terms of, you know, your things, but as you lose more data or have more people drop out or assessments not done, you're losing additional efficiency that can have big impacts on your power at the end.
And I guess I think on that last part, you know, if you have a limited sample size, it's not really a question of whether you should sacrifice precision or randomized design, because you're probably, or if you're doing a randomized design to try to estimate a treatment effect with a small sample size, you are not going to have much precision. You know, there's not a way to get, I guess, necessarily precision out of that situation. So you have to think about what can you optimally learn about, and is it better to learn about variability in the endpoint? But this is sort of couched on this underlying problem that you may have a rare disease with something that has really strong biological plausibility. And then it's sort of, you may be in a situation, how do you do a pure natural history type study when you have a candidate agent that you really need to start figuring out how to learn things about? And I think that is the labor of love in terms of talking to the right people and the right statisticians and thinking about whether there are alternative designs that can help you efficiently learn, you know, whether it's, and again, in Chris's and Melanie's lectures, they go through some of these other approaches, whether it's a series, you know, a series of N of 1 designs for a chronic disease where people are getting on and off a treatment and you're learning about their individual treatment effects and then meta-analyzing them. There are a lot of creative options potentially, but they may not be things that your local folks are super familiar with. So thinking about, you know, kind of collaborating maybe outside your usual sphere and looking up people who've used these designs before and trying to get in touch with them and really thinking about the best way to address your unique situation. Because I think we owe it to our patients in the rare diseases to try to come up with the best scientific thing and not just throw up our hands and say, it's too hard. You know, I think we really have to think creatively, but it involves sometimes a lot more thinking up front. And obviously we all have pressures academically, get promoted, treat the next patient well, discover things. So, but I think the time is well spent in thinking carefully about really coming up with a plan on how to really tailor the trial design to the situation.
There's a question in the chat box from Dr. Goodspeed.
So the question's about you know, proxy report measures in populations into studies, and I think again, I think there are a lot of validated proxy report type measures or measures that can be reported by a proxy. I think it is good to start to think about how patients and their families are impacted by diseases. But I think, you know, the sort of standard scientific caution in that, you know, some separation from the exposure, whether that's a randomized treatment and so forth, can aid in interpretation later when there is the potential for the knowledge that you're getting something to influence how you might feel or report on those things. I mean, I hope I'm answering the question, Kim, but if I'm not answering it, maybe you can retype it and Chris or Melanie can get it better.
It made sense to me. I think it's, I mean, the other operational piece we haven't really touched on is, you know, if you can randomize, you keep a lot of the properties and you avoid some of the issues of bias. But in rare diseases, it's often really hard to randomize because if it's a rare disease, there are no treatment options. People may not want placebo, and I mean, you can, you know, design it and have that conversation. But it is something that will be something that will be important to keep in mind as you're designing the study. And I think, you know, with social media and chat groups being more now, it's easier, I think, for people with rare diseases to connect with others with the disease than it was 10, 15, 20 years ago. And so, you know, those things have to be, you know, there's a lot of non-statistical questions that come into play too, in terms of, if you put an excellent design that requires one-to-one randomization to treatment and placebo, and nobody with the disease is willing to take a chance of getting placebo, so you can't recruit, it doesn't do you any good.
Yeah, and I mean, if the disease progression or endpoint is appropriate to it, I mean, sometimes there's ways to to potentially get around that, like by using a crossover design where everybody is eventually going to get the treatment, but you get to measure the progression for some period of time in half of them, and then they get crossed over the treatment. Again, it's not appropriate for every situation, but it does at least get out of that individual thing of either you're going to get the drug now or in 3 months. We're not going to let you know which of those it is. But either way, this will allow us better to, you're not getting into a study, and that I think comes up as an opportunity cost as well. We've certainly seen that in COVID. Like, well, should I, and we're probably all even thinking about that for those of us that are healthcare providers. Like, should I be in this vaccine trial? Or I get a half shot of placebo, maybe another vaccine will come along and be approved. But do I want to be in that vaccine? Will its long-term safety data be well characterized enough? And I think for a patient as well with a rare disease, some of those questions come up. There's an opportunity cost to being in a trial. What if a new treatment's on the horizon, is about to be approved? Or is there something else that I can't be getting because I'm in this trial? So those things are all, very, very complicated and very important issues to think about. Okay, and I see that, yeah, that I think Dr. Goodspeed is pointing out that some stakeholders, which I might think of as funders, whether it's academic funders, insurers, or others, have some issues with the proxy measures. And I think, I think it's a matter of sort of doing the homework. Sometimes you can go to things that have been developed, like from the NeuroQual or the PROMIS sets, where there's just a larger scale experience with what population norms are for those scales, even though the disease specific ranges on those may be an area of development. But I think try to do the homework as best you can, and as best you can separate what people are getting, what the treatment course is or the intervention is from the measurement of those. That helps, I think, give it more of an imprimatur of validity. Well, I think we've covered most of the questions. We will slowly walk towards probably we may be wrapping this up to give people a few minutes potentially before they have to get on another Zoom call. We'll see if any other questions pop in. Any other things, any other sort of parting thoughts, Chris or Melanie?
I have one. I saw Laurie Gottman joined us late, but I just wanted to point out to everyone who's on here, this is Laurie's last official day at University of Iowa. So we're going to miss her and wish her the best of luck as she moves to Indiana.
Thank you very kindly, Christopher. I am excited to be moving on and sad to be leaving Iowa, because there's only, it's 75% vowels but 100% awesome.
Excellent. Really thoughtful. As an Ohioan, I wish we had come up with that there, but that is all Iowa. All right. Well, I think with that, please, you can go to the top of the chat for the link to the link for the webinar evaluation. Also, please do consider watching the rare disease and small sample size full videos if you haven't already. They're really great, and they go into a lot. If you do have a little time, it can help really illustrate some of these concepts with some real, actual, concrete and tangible examples of what solutions others have used in these cases. But with that, I think we will adjourn at this point in time, and join me again in thanking the panel. Everybody have a good rest of your day.
Thanks, everyone.
Thanks.